I am Dike Ojji. I'm interested in global cardiovascular health, especially in low and middle income countries. Also interested in hypertension clinical trials and in establishing a system for hypertension treatment and control in primary health care facilities in low and middle income countries, especially in sub-Saharan Africa. Hypertension, like most other cardiovascular risk factors, is quite prominent in Nigeria. The prevalence of hypertension has been put at about 30% in adult Nigerians, those that are above 80 years and above. And worse still is the fact that control for previous meta-analysis of different studies done in the country has shown that it is very poor, as low as 9 to 10%. And we know today that hypertension virtually drives cardiovascular disease in Nigeria, from heart failure to cerebrovascular accident or stroke to coronary artery disease and also to chronic kidney disease. So hypertension is big in Nigeria, just like most other parts of the world. And because of a large population, if you have a prevalence of 31%, that translates into a very huge number. Myself and Professor Mark Hoffman started the hypertension treatment in Nigerian program, and our strategies are according to the WHO HAS package. And what we set out to do is to try and tackle the burden of hypertension starting at the community level. What we are doing is that we are using non-physician healthcare workers in form of team-based care, training them to try and treat hypertension in the Nigerian population. And part of the strategies we are using, according to the WHO, is also to promote fixed dose combination or single peak combination in this group of persons. And another strategy is to make sure that there is a drug supply chain which is maintained. The drug revolving fund is a process whereby medications are purchased in bulk and then distributed to these different healthcare facilities. And that means that patients are going to get it at a cheaper rate. Why? Because there is bulk purchase. So there's a little markup. So they get it at much cheaper rate compared to the community pharmacies. So that is why. And we've tried to use that to maintain a supply chain in these facilities. And apart from that, we've also tried much of to make sure that the basic equipment for managing high blood pressure, that the basic blood pressure machines are also available in these facilities. And we also, in addition, do a lot of monitoring visits to these facilities to make sure that the strategies, are well adopted. And over time, we are seeing an improvement in adoption of these strategies, especially as regards reports on the patient case cards, whereby these non-physician healthcare workers document the blood pressure of the patients and comorbidities and so on. Community engagement is just a strategy of dialoguing with a set of people within the given area, and so that your intervention will be well taken, your intervention will be successful. And key in community engagement is trust. The mistake people make in community engagement is to come in and then breach your intervention on the people. But in community engagement, there must be dialogue. Even though as a scientist, you know the evidences, but you don't just push the evidences. You have to explain why those evidences have worked, where they have worked before, and why you feel they will work in that community. For community engagement, we mapped out the different stakeholders, and these stakeholders include healthcare practitioners, from physicians to non-physicians, to policy makers, to what we call opinion leaders in the community, to also the patients themselves. So what we did was to get to their communities, and we scheduled meetings. And how were we able to penetrate? We use these non-physician healthcare workers to be able to reach out to them. We also use what we call the health promoters and health educators who work in this system to be able to reach out to them. So we invited them into these primary care facilities, and we had some in-depth interviews with them and also focus group discussions. Apart from that also, we had some larger stakeholders meetings whereby we're able to explain, why hypertension should be treated, the dangers associated with not treating hypertension, and even the dangers associated with not checking your blood pressure as frequently as possible. One issue about the community is that when they trust you, they want you to deliver. But unfortunately, before this time, they might have had some disappointments. So that is one challenge, that I know we had initially. But how were we able to navigate that? We used the people they trusted, using the health care practitioners, non-physician healthcare workers, using the health promoters, health educators to tell them that this is different, and also to make them realize that hypertension is a general thing, and there's hardly any family, you understand, in those communities that will not have an individual, having high blood pressure. So with this, we're able to, get their buy-in. But then they reminded us that people have come before with similar programs, and along the line they abandoned them. That hope as will not be the case. And good enough that over the time we are not disappointed, and this program has continued. I remember when we engaged the community, one of the things they pointed out was the fact that if we don't get the medications either free or at reduced prices, there was no way the intervention was going to work. And it was good that we had some support from Northwestern University and also from Result to Save Life to be able to maintain a supply chain for about 18 months of free medication before we transitioned into the drug reward. So somehow we have been able to build their confidence, and now anytime we call for stakeholders meeting, they are just willing to come. They are very happy with what we are doing here. We told them that even though they might have had some disappointment in the past whereby programs are promised and failed, this is going to be different, because what we want to do is to make it possible for them to have ownership of it, because hypertension is big, hypertension cuts across, and so they should be interested in that. So in terms of getting their trust, it's dialogue. We kept on reassuring them over and over again, and then we also identify very key opinion leaders in those communities and interacted with them, so that anytime we called for a meeting, as far as those people were in support, then the people were quite willing, to come. So dialogue, communication, persistence is part of it, and then being able to deliver, it improves trust. I think one thing about community engagement is that there must be trust. When there is no trust, then community engagement does not work. And then again, respecting the opinion of those communities is very important. So we did respect the opinion, and that was why, as part of our strategy, we tried as much as possible to maintain a supply chain here.
So this slide shows the timeline when we initially proposed the study starting in 2019. You can see that there was an initial sampling, initiation, focus group discussions, and training across the 60 public primary care facilities. We thought there may be some primary care facilities that might not wish to continue to participate in the study in 2020. This was before we obviously knew about the coronavirus pandemic. We're lucky that all 60 sites have continued to participate in the study. And here we are in year 4, nearing the final quarter of year 4. You can see the sequence in which the different components of the Kaiser Permanente WHO Hearts strategies are being implemented across 2020 to 2021. And along the bottom, you can see that we've been conducting community advocacy and awareness campaigns. Our team has led more than 250 of these community awareness meetings to ensure that communities living close to these primary care facilities know about the availability of services and are aware of what that entails. And that allows us to create demand for services rather than creating something that nobody will come to. Think about how you are engaging your community to increase demand for the services that you'd like to increase. So these data show a summary of the participants who've been recruited from January 2020 to May 2022. Over this time period, we've recruited more than 16,000 patients from 60 primary healthcare facilities. So overall, through May of 2022, we had more than 80,000 primary healthcare visits. The mean age was 48.4 years. 69% of the participants were female, and almost half, or 48%, had a new diagnosis of hypertension. 27% had no formal education, meaning that these are individuals who have had no formal schooling throughout their lives. And over the study period that were shown here, monthly control rates for hypertension have increased from 20% to 52%, demonstrating the effectiveness of this multi-level package over the study period. Now, this figure has a lot of colors, and I want you to be thinking about how to conceptualize, presenting a large amount of information, thinking about the dynamic way in which patients come into clinic, receive care, sometimes drop out of care, and come back. You can see the different boxes, Abuja, Municipal Area Council, and so on, represent local government areas within the Federal Capital Territory. So this figure, which was created by one of our PhD students, Jen Chang-Ye, shows that on the x-axis is time. Each one of the lines is an individual participant, so there's more than 16,000 lines in these 6 figures. The color coding shows that when it's red, that those are 2 time points where the individual does not have their blood pressure controlled. So you can see on the left-hand panel, when most people come to clinic on their first visit, it's red, they're not well controlled. Over time, you start to see a change from red to yellow, which is that transition period, to more green, meaning more participants are green than were red. And we see that in the hypertension control rates. So I want you to be thinking about the way in which you're going to present the data that you show, sharing that richness of data in the system level intervention you might be planning.